In this next section, we're going to talk about basic electrocardiography. Now, the point of this section is not to turn all of us into cardiologists, but simply to understand the electrical activity and its association with the myocardial activity. Let's review some terminology. Depolarization refers to when sodium enters the cell. So at the bottom of the screen, we have the extracellular space, there's sodium, and then we have a cell with intracellular space, and the sodium is trying to get into the cell. Under resting conditions, the inside of the cell is more negative, about minus 70 millivolts. So when sodium enters the cell, that causes depolarization and a change in this electrical charge of the cell. It basically goes to zero. Repolarization is when sodium is pumped out of the cell and back into the extracellular space. An electrode is simply a piece of metal that is conducting an electrical signal. So we use electrodes to pick up the electrical activity that is going on inside of the heart. One of the things that is important for all of us to understand is that as humans, we are electrical. That's why sticking a finger inside of an electrical outlet is not a very bright idea, because it's going to disrupt the normal electrical activity inside the human body. An action potential is simply an electrical signal. That electrical signal is generated by depolarization and repolarization. The electrical components of the heart include the sinoatrial node, or the pacemaker, the atrioventricular node, or the AV node, the AV bundle, also known as the bundle of His. This bundle of His then branches out into the right bundle branch and the left bundle branch. And the fibers along this bundle of His, as well as towards the end, are called Purkinje fibers. There is some debate as to what's called Purkinje fibers and what's not. For all intents and purposes of this class, you can consider any of the fibers along the bundle of His and the right and left bundle branches to be Purkinje fibers. Depolarization begins with the SA node. That depolarization then spreads throughout the atria, across those Purkinje fibers. Eventually, the electrical activity hits the AV node, which causes depolarization of the AV node, which then causes the depolarization of the AV bundle, all the bundle branches and Purkinje fibers. Eventually, this depolarization spreads across the ventricles. Electrical conductivity happens very, very quickly. As you can see from this diagram, that electrical signal originates in the SA node and spreads out to all those Purkinje fibers in 0.21 seconds. So that's very, very fast that this happens. In order to understand how electrical activity is propagated within the myocardium, we need to understand vectors. If we have a square box down here that is negative and we have two electrodes that are positive, electrical activity is going to flow towards the positive electrodes. So we may get electrical activity that looks like this. These are called component vectors in physics. So we have electrical activity that's going up towards that positive electrode, and we have electrical activity that's going to the right to that positive electrode. We can average out this electrical activity into something called the resultant vector, which has both direction and magnitude. We can describe the electrical activity in the heart using these vectors, known as cardiac vectors. From the SA node, we have electrical activity that's spread throughout the atria. All these pink vectors represent electrical activity being spread across the atria. Eventually, the AV node is depolarized, and then that causes electrical vectors to spread across the ventricles. We can summarize the electrical activity within the heart using that resultant vector. This is called the mean electrical axis of the heart, and it tells us a lot about the average electrical activity within the heart, particularly in the ventricles. If I place an electrode at this point, since the mean electrical axis, the electrical activity is going towards that positive electrode, I'm going to get a positive deflection in my graph. If I place a positive electrode inferior to this mean electrical axis, then I'm going to get a little blip on my EKG strip that looks something like this. Some of that electrical activity will deflect upwards, some of it will deflect downwards, representing both positive and negative deflections respectively. Why is this happening? Because there's some electrical activity that's going towards this positive electrode and some of it's going away. If I place an electrode off to the right side of the heart, since electrical activity is going away from that positive electrode, I get a negative deflection that might look something like this. This provides us with the basis for what we see in an electrocardiograph. On the y-axis here, we have voltage. Since we are electrical, we can actually measure the electrical activity in volts. The x-axis is 0. This is what we call the isoelectric line. So this line represents no electrical activity. The first deflection that we see in the EKG is what we refer to as the P wave. This represents atrial depolarization. The next line represents the PR segment. This represents the delay in transmission at the AV node. If we combine the P wave with the PR segment, we call that the PR interval, and this represents the propagation time of the stimulus from the SA node through to the atria and the AV node. So intervals include both waves and segments, whereas segments do not include waves. The next series of waves is referred to as the QRS interval. We have the Q wave, which is a negative deflection here. We have the R wave, which is a positive deflection. And then we have the S wave, which is a negative deflection. This represents ventricular depolarization. This is followed by the ST segment, which is the beginning of ventricular repolarization, followed by the T wave. The T wave is the continuation of ventricular repolarization, and it's represented by a positive deflection. It's important to note that the T wave defies the logic that we've already established, and that is if electrical activity is going towards the positive electrode, it manifests as a positive deflection. But in this case, we have electrical activity that's going away from the positive electrode, but manifests as a positive deflection. So that is something that you're going to want to take note of, that this defies the logic that we've already established. In general, electrical activity going towards the positive electrode results in a positive deflection. In this case, and it's the only case where this happens with the T wave, that we have electrical activity going away from the positive electrode, but yet it is manifesting as a positive deflection. Why does this happen? Research suggests it has to do with the order in which the cells are repolarized. If you're lucky, you might actually see the U wave. The U wave is what we refer to as latent ventricular repolarization. However, this wave is rarely seen. It usually gets absorbed into the T wave and is not distinct. And so if you're working cardiac rehabilitation, I wouldn't expect you to see this very often. Then we have the QT interval. Since this is an interval, it's going to include waves. It starts at the Q wave and terminates at the T wave. Of course, the cardiac cycle repeats, and we have another set of electrical waves. When we look at the R to R interval, we're looking at the waves from the first QRS complex to the second QRS complex using the R wave as our defining point. You can use the R to R interval to determine heart rate. So if you had a long strip of EKG paper, you could actually count the number of R to R intervals and mathematically determine what that person's heart rate is. Let's look at electrode placement. We have a right arm electrode abbreviated as R, a left arm electrode abbreviated as L. We have the ground electrode represented as RL, and for the most part, you're going to ignore that in the following slides. We have the left leg electrode, or LL. In lead 1, the right arm electrode is negative and the left arm electrode is positive. In lead 2, the right arm is negative and the left leg is positive. In lead 3, we make the left arm negative and the left leg positive. When we put these together, this is what we call Einthoven's triangle. These are what we refer to as the bipolar limb leads, and they look at electrical activity on the frontal plane or the coronal plane. What's interesting is that we can take these limb leads and intersect the lines to come up with a hexaxial reference system. So these lines are exactly what we just saw in Einthoven's triangle, except we move them so that all the lines intersect at one point. That separates the heart into degrees. Lead 1 looks at the electrical activity of the heart from 0 degrees. Lead 2 looks at the heart from a 60-degree position. And lead 3 looks at the electrical activity from a 120-degree position. We can add the corresponding negative angles, 120 and 60 respectively, to complete this hexaxial reference system. Let's put this together with the mean electrical axis. If we look at lead 1, remember lead 1 makes the right arm negative and the left arm positive. You can see that we've got some mostly positive but some negative deflections on our EKG graph. That should make sense since the mean electrical axis tends to flow towards that direction. In lead 2, we have the right arm that's negative and the left leg that's positive. This should result in a mostly positive deflection since the mean electrical axis is lined up more going towards the positive electrode. In lead 3, the left arm is negative and the left leg is positive. This results in both positive and negative deflections. This should make sense because the mean electrical axis is telling us that some of the electrical activity is going towards this positive electrode and some of it is going away. Dr. Einthoven further explored the use of his limb leads that he developed and came up with the augmented voltage leads. Remember, if you augment something, you're enhancing it, you're making it greater. So with these leads, what he ended up doing was he made both the left arm and right arm negative and then the left leg being positive. That's what he called augmented voltage foot, or AVF for short. With AVR, augmented voltage right, we have the right arm that's positive and the left arm and the left leg are both negative. In AVL, augmented voltage left arm, we have the left arm that's positive and the right arm and the left leg are both negative. We can also put these on the hexaxial reference system and look at more pictures of the heart. In AVF, we have the left leg that is positive. And remember, the right arm and the left arm are both negative. This results in mostly positive deflection because the mean electrical axis tends to go in that direction. In AVR, the right arm is positive and the left arm and the left leg are negative. Since the mean electrical axis is going away from AVR, that means we're going to get negative deflections. In AVL, we have the left arm that's positive and the right and left leg negative. In this EKG strip, we can see that there's both positive and negative deflection. This tells us that there's electrical activity going towards and away from the positive electrode. Einthoven's triangle can be confusing, but one way to look at it is as if you had cameras posted at all of these electrodes so that you're getting different viewpoints of the heart. And that's all that the EKG allows us to do, is just look at the heart from different vantage points. Just like if we took a picture of a car from different viewpoints. Each of these angles represent the same car, however, we're looking at it from different viewpoints. Same thing with the EKG. We can take all the leads from Einthoven's triangle and lump them together for diagnostic purposes. For example, the left lateral leads are lead 1 and AVL. This is where we have a positive electrode on the left arm. These are very useful to tell if we have any kind of infarction in the left coronary artery. Whereas the inferior leads, which are 2, 3, and AVF, can tell us if we have an inferior infarction. As you might have imagined, we also can look at electrical activity on a horizontal plane. So that's if we slice somebody in half, just like you see in this picture here. Those leads are what we call the precordial leads or the chest leads, and they're numbered from V1 to V6. The diagram in the bottom right-hand corner will show you that as we change the position of the electrode, we're going to change how we view the heart and the deflections that we might get from each of these positions. So in a 12-lead EKG, we've used 10 electrodes to get 12 pictures of the heart. Remember, all of these represent the same electrical activity, they just allow us to see the electrical activity from a different viewpoint, which does have some diagnostic merit to it. A typical EKG machine might look something like this, where you have a printout that you can sample the electrical activity. Usually you don't have a continuous amount of paper being outputted unless you're doing something diagnostically. Usually it's just a sample. I would also like to mention that in the picture on the right, you see the placement of the electrodes for exercise. Remember, when we were talking about the electrodes earlier, we were talking about right arm, left arm, etc. And those are typically in a resting EKG done at the wrist and the ankles. But during exercise, you obviously can't have electrodes placed on your moving limbs because you'd trip or rip the wires out from the machine. So you place them at these locations in order to be able to do a graded exercise test in combination with an EKG machine. Essentially, the electrodes that were placed in the arms and legs are now moved to the shoulder area as well as the hips. The V-leads aren't placed any differently in a graded exercise test versus a resting EKG. So here's a little case study for you to think about. Recall that the electrical axis represents the average direction and magnitude of depolarization of the ventricles. It is biased towards the left ventricle because of the difference in mass between the left and right ventricle. What would you expect to happen to the mean electrical axis over time in a patient with chronic pulmonary edema? Why? And how would this be reflected in a change in the R and S waves in the precordial leads? The mean electrical axis is going to change depending upon the amount of muscle mass that we have in the myocardium. As you've seen in the slides, the mean electrical axis tends to favor the left ventricle. It's of course more muscular, so there's more electrical activity. If I change this and shift it towards the right ventricle, then that means I must have gotten right ventricular hypertrophy, which is actually a bad situation to be in. So think about this electrical axis in relationship to the amount of muscle in the myocardium. The more muscle mass, the more electrical activity in that particular area.